Let's get a little noise going. Let's have some energy here because I'm excited to be with my family, my people. When I left, my son said, "Mom, tell my people." I said, "Hello." Because we're all the people with the big heads, the big forehead, and the funny little bumps, lumpy, bumpy disease, as Dr. Ng used to say. So it's my honor to step in and introduce our next speaker. And let me tell you before we get started, because if you give me a mic, I tend to go off. Research in this symposium is important to me, and I'm going to tell you why. Because I have children, as many of you have children, as many of your children are here potentially. And this research, which I know we're advocating for, but we need to go beyond advocacy and make it happen, because this is about the future. Can I get an amen out there? There you go. All right. So let's keep it going. We're counting on you, Dr. T. You got this. All right. So I'm delighted and honored to introduce our next speaker. It's Dr. Suzanne MacFarland. She's the Assistant Professor of Pediatrics and attending physician at the Children's Hospital of Philadelphia and I can't read it because the Perelman School of Medicine. Did I say it right? Oh, close. Okay, good. At the University of Pennsylvania. She's the Associate Director of the CHOP Cancer Predisposition Program. Her research and clinical work focus on children with cancer predisposition syndromes. Round of applause for Dr. MacFarland.
Thank you so much. Small disclaimer, I've learned that trying to give a talk pregnant, I get a little breathy, so I apologize in advance if I have to catch my breath. And that video was quite something to follow, and it just makes me feel even more passionately to hear all those voices saying how important this is. And I agree with that. It's actually what inspired me to start our multidisciplinary P10 clinic at CHOP, just because I saw how many patients really had these diverse needs and how much we could do to bring things together for them. So. Thank you. All right, so I started out actually as a polyposis person, looking at cancer risk in children who developed polyps of their gastrointestinal tract. And then over time realized that patients with P10 were really coming up over and over again, and they really didn't have a medical home, which is what sort of brought my interest forward. I mean, they do have a medical home in Cleveland Clinic and other places, but at CHOP, they did not have a medical home. And so I wanted to develop that. I have nothing to disclose, but did just as everybody else, I think, want to just express my deep honor and respect to have been a colleague of Dr. Kara Zhang's and how much she's influenced my work. And so I'm going to talk a little bit about the pediatric diagnosis of PHDS, refer some of the manifestations, and I think I'm going to preview some of the talks that are going to come throughout the day. I'll do a little bit of a focus on GI polyps, and then I'm going to talk a little bit about cancer screening in childhood. My first conversation with any family is always a focus on the low risk of cancer in childhood. So trying to remove some of that worry early in life, but also to remember the thyroid and make sure we are thinking ahead about that. And so I know that Dr. T gave a great talk about this already. So we already talked about some of the manifestations. Usually in childhood, it is the larger head circumference. I hear often from families that their child was told that they had macrocephaly, but then without other manifestations, it doesn't always get picked up right away. So I do think parent advocacy has always been really important. Parents saying there's just something else going on here. I think we should do genetic testing often leads to this diagnosis. If you combine that with developmental delay, autism, or similar phenotypic features, that can also help to make the diagnosis. And then thinking about those syndromic manifestations for things like Proteus, benign Riley-Rubalcaba, can also help to make the diagnosis. And then, of course, the family history of disease. But as we've heard today, many, many patients are de novo, meaning they're the first ones in their family to carry the mutation of the P10 gene. And there are these lovely testing criteria that have been developed and are freely available on the Cleveland Clinic website. These are very useful to clinicians in thinking about, does my patient meet criteria for testing? And that does depend on criteria such as the macrocephaly and at least one of the following things listed there, including some of those syndromic features. So some of the things we think about in children with PHTS include the developmental and behavioral phenotype. And I think that this is really, really important to recognize. I actually think a developmental pediatrician should see every single patient who's diagnosed because phenotypes can be really subtle. There are also the neurologic manifestations. We have noticed some changes in immune function. And then I kind of lump all of the lumps and bumps into the overgrowth part of having a PTEN mutation. So polyps, vascular malformations, lipomas, skin findings can all fall under that, that group. And I know that we have an incredible dermatologist here to talk about the skin findings, so I won't go into detail, only to say that these are sometimes the things that bring these patients forward as well. So the frequency of autism spectrum disorder has been reported previously as around 25%. As we've actually studied this further and have involved a developmental pediatrician in the assessment of all our patients, we're actually picking up more subtle phenotypes. Sorry, I keep using that word to a room full of patients and families, I apologize. Phenotype just means how a patient, all the features a patient has. And so we've actually picked up some more subtle diagnoses, which has actually been really helpful in getting supports into place. That's why I find that this evaluation is really important. There's also developmental delay that is not related to autism spectrum disorder and other neuropsychiatric findings. So things like ADHD, anxiety, OCD, and just differences in things like adaptive functioning, sensory processing. So even if you don't meet criteria to have an autism diagnosis, you might just have some difficulty processing certain sensory things. And that's important for us to find out about because we can help with that with therapies. And so it really is important to involve a developmental pediatrician in care for patients with PTEN mutation. I say that knowing how hard it is to get it in with a developmental pediatrician. That's the reason we actually integrated one into our clinic, because otherwise the wait times can be a year or longer. And I will preview Dr. Fraser's talk and not go into too much more detail there because he's the expert. I think thyroid pathology is also something that comes up a lot. There are a high rate of benign lesions that can be monitored. So I think previous thinking was that we should be aggressive in removing thyroid tissue. I think we've really moved away from that. Multinodular goiters, so like kind of a lumpy, bumpy thyroid essentially, can precede malignancy, but it also can not be malignant. So it's really important to be seeing a thyroid expert who can really help you to differentiate what needs to be biopsied, what can be monitored. And then the type of thyroid cancer we see is differentiated. It's about a third of patients in their life. It is incredibly treatable with surgery, which is the good news. But it's only 5% of patients under 20 years. So even though we start that monitoring in childhood, the risk is actually very low. And then there's the two different subtypes. There's the papillary and the follicular, and the papillary is more common. There's also the neurologic changes. So a lot of children that I see have been diagnosed with hypotonia, meaning that they just have low muscle tone. There's also findings on brain MRIs, and I know that doing screening brain MRIs comes up a lot for pediatric patients. A lot of patients I see have already had a brain MRI because they were diagnosed in the setting of having a larger head circumference. And we do know that there's, in about half of patients with PTEN, if you put them into an MRI scanner, you're going to see some differences. That might be bigger perivascular spacage, which is kind of the spaces around the brain tissue. The white matter changes, that's that little arrow right there. We see a higher frequency of things like Chiari malformations, which when they're that low grade, that type 1, don't cause any symptoms, but do need to be monitored. And these can be present with and without actual symptoms. So my feeling, and I think a lot of us feel, that we should only do brain MRIs in the setting of symptoms, because if you see something and it's not actually causing any problems, it's really hard to know what to do with that. And that's going to lead to a lot of stress and anxiety. And I also like to avoid imaging in children when you need sedation, because we want to limit risks. But if there are any concerning symptoms whatsoever, we do get a brain MRI, and sometimes we find things we could follow over time. We also know that supportive therapies are required in the majority of patients with a PTEN diagnosis. So that's things like speech therapy, occupational therapy, physical therapy, behavioral therapy. That's again why I think involving a developmental pediatrician is really early, because the earlier you intervene, often the more of a difference you can make before they reach that school starting age. And then this was a wonderful article that came from the Cleveland group that just shows the spectrum of findings. I know the text at the top there is kind of small, but it's mentioning all of the different neurologic findings, both physical, things like the macrocephaly, the high arch palate is in there, Kristen. I know you mentioned that. And then other facial findings. And then the graph at the, I don't know if my mouse shows up there, yeah. This graph right here is just showing the difference in trajectory of the patients with the PTEN mutation, which is the solid lines, versus control patients who don't have a PTEN mutation. So you can see just that head circumference trajectory I think we're all familiar with. Immune function is something we also talk to a lot of our patients about, and we actually also have an immunologist, Dr. Ruffner, who follows and evaluates patients in our clinic. This is an active area of research. We've really been trying to figure out exactly what the spectrum is. But this graph on the side here actually shows that most patients with a PTEN diagnosis may have some changes in that pathway that we know about, which is involved in your immune system's function, but it doesn't actually affect their immune system's ability to do its job. So most patients with a PTEN diagnosis have a normal functioning immune system that does not cause any problems with their ability to fight off infections. But there is a small subset who have some differences. And for that reason, we feel like if there is a history of things like frequent infections, it's important to have that evaluation. Things that we think about in terms of those symptoms would be things like recurrent respiratory infections, infections that require multiple rounds of antibiotics, a poor response to vaccines. So you get your vaccines, but then you check the blood and the vaccines didn't take. Those are all things that we're looking for. I also, the frequency of patients needing their tonsils out is pretty common in patients with PTEN diagnosis. And we also sometimes see what looks like polyps on the GI tract, but then you take them out and it's actually just essentially big lymph nodes. And that's because patients with a PTEN mutation can have something called lymphoid hyperplasia, which means that the immune system is working, but the tissue itself just gets a little bit big. That's important just because big tonsils can cause things like sleep apnea. So we do try to pick that up if we see it. We also can see something called hypogammaglobulinemia, which is a long word for your antibodies are not being produced in the normal ratios. And that can lead to things like poor vaccine response, and you might need more frequent boosters than other people would for your vaccines. And then there is also an increasing, especially with things like, wonderful resources like the PTEN registry and other registries, we can see things like autoimmunity at higher frequencies than the general population. So those are all things that we think about evaluating for. And this is just another lovely paper that just came out this year. And that's just showing the blue bars are patients with a PTEN diagnosis, and the gray bar is the controls. And you can see that the frequency of needing your tonsils or your adenoids out and the frequency of infections during childhood is higher in both populations. I don't say any of this to suggest that children with PTEN are at risk for severe life-threatening infections, but more just that it's something to have awareness about so that an immunologist can do an evaluation if it does seem like things are happening more frequently. And then what got me first involved with patients with PTEN diagnosis were the gastrointestinal manifestations. And this was a study that we did together with Garris's group a couple of years ago, just looking at what are we actually seeing in the gastrointestinal system in PTEN patients. And so we know that patients with PTEN mutation can have polyposis. And now we're also recognizing more and more that sometimes we see eosinophilic disorders, which means things like eosinophilic esophagitis or EOE. We also saw that patients had a higher frequency of things like constipation and feeding issues, and that was both the patients with and without an autism diagnosis. So you can see half of the children we looked at had underlying constipation. And that's a real lifestyle thing for small children. So that's really important to recognize and treat early. And similarly, feeding issues can really respond to feeding therapies if you recognize them early. There are also non-polyp things on here like reflux and esophagitis, and then dysmotility, which means that food doesn't move as quickly through your system or moves at a different rate than it does for other patients. So these are all things we've started to recognize more and more in patients with the PTEN diagnosis. And then we think about polyps. There is, we recommend screening in adulthood. It starts at 35 for patients with P10, but we actually have really recognized that it presents much earlier in some patients. And we call it a mixed polyposis, which means you don't, like, if in other diagnoses like familial adenomatous polyposis or juvenile polyposis, you get one polyp type. In PHTS, we really see that you get all different polyp types. And that actually is usually a flag that we always tell our gastroenterologists, you should refer them to us for testing, because if you see two different polyp types, it's probably going to be a P10 mutation. And so in pediatrics, we really do see that something like 10%, I think that number might actually be a little higher as we recognize it more, have polyposis. And most of those presented in the setting of symptoms. So things like bleeding, blood in your bowel movements in a kid with P10 is always something that should be flagged and recognized. Things like dyspepsia is a word for like kind of stomach discomfort after you eat. Constipation usually is just constipation, but sometimes ongoing or difficult to treat constipation or constipation that switches back with diarrhea. It could be irritable bowel syndrome, but it could also be polyps. So that's why with P10, you should just have that additional flag in your head to look into it. And then abdominal pain. And you can see this graph is just showing the different types of polyps. The most common are things like inflammatory and juvenile polyps, which are also the more common types of polyps we see in children in general. But then other ones like ganglioneuromas fundic gland polyps in the stomach, we also see. And then lymphoid aggregate is kind of like that, kind of like I said, there's the big tonsils, and then there's the big, big tissue in your colon and your stomach, and that's this bar right here. So we really do see a lot of different polyp types. The important thing to remember in children is that these are polyps, which means they're an overgrowth of that normal intestinal tissue. They are not cancer, and it takes a very long time for these polyps to turn into a cancer. The important thing is just to recognize them and remove them as you see them. So I think it's really good that we are starting to recognize them and pick them up in pediatric patients, but I always really want to reassure people that these are not cancer, nor are they close to becoming cancer. When you find them in a child, we really don't see any colon cancers in children. In adults, up to 90% of people with PHTS do have polyps, so that's why we do recommend if you haven't started colonoscopies by 35, you should start them then. And then these are just some pictures of the differences between the polyps. This is more of a, what a pathologist would see under a slide when they look at them. But they really are, they fall into two different categories. And this is why patients with P10 do have a little bit of difference. Usually you just get one of these types of polyps, and they're very different in terms of how much inflammation is there, how kind of the tissue at the surface has changed. But they're all ones that can be removed and treated. This is not a polyp, it's just inflammatory tissue. So we see this sometimes too. So you may have a colonoscopy and have an inflammatory pseudopolyp removed. That just means that there was a little area of where the tissue got angry, not that it was a polyp. And then we also see ganglioneuromas, and these can be actually quite frequent. And we have some patients who have ganglioneuromatous disease. That's just kind of like a polyp of almost like a nerve tissue in the colon. And again, these are not cancerous, and they don't turn into cancers. So just important to find them and remove them. And then polyp screening with colonoscopy is really only in the setting of symptoms. And I think I mentioned all these symptoms already, but things like changes in the bowel movements and blood in the stool. And then if they're found, usually we have a discussion about how often to repeat from there. If you find a couple of polyps, you don't necessarily need to go back every single year. Sometimes we'll do every year for a little while just to see how quickly they're developing. But then that can be spaced out over time. The other thing that you can consider is just testing the stool for blood. So if you're worried about polyps, there's a kind of stool card you can send into your doctor. They do it 3 times, and that's another thing we sometimes consider. I won't go into detail about vascular malformations because Dr. Eng is going to be speaking about this very soon. But these are something that we also see in patients with P10 mutation. And then as we said, lumps and bumps. So things like lipomas, which are fatty tissue, fibromas, which are more fibrous. These can all show up. I always tell patients, please call me if you're worried. We probably will not intervene. We probably will not even need a biopsy because the cancer risk is very, very, very low. What I don't want is for somebody to have multiple surgeries for a lipoma when they're ultimately very benign. They also sometimes grow back after surgery too. So I think that sometimes people are a little bit more aggressive when it's a child and they find a lump or a bump. And so it's important to have an evaluation and be sure that that procedure is needed. And then I did want to touch briefly just because, I'm a pediatric oncologist too. And so we do think a lot about pediatric cancer screening. And the only real risk in childhood is thyroid cancer. And that risk is 5% under 20. So it's there, but it's pretty low overall. And we want to make sure that we are doing screening in a way that we're picking up things that are concerning, but not over intervening, and try and help that kid to live as normal of a life as possible. And so we've recently actually updated the guidelines for the age of thyroid screening. It used to be 7. We're actually going up to 12 now based on some really good information that we're not picking up anything dangerous in that screening between 7 and 12. And actually in Europe, I think they might even be going up to 18 soon. I think we wanted to keep it still within the pediatric age range so we can start those evaluations. But we also are recommending that it is possible to space out to even to every 2 to 3 years. Dr. Bauer is going to talk more about this today, and he's the thyroid expert. But these guidelines were actually written with Dr. Ng's input as well within the last year, and they should be published very soon. We also, I know that our next talk is going to be about breast awareness and breast screening, so I won't go into this in detail, but this is something I start to talk to teenage girls about, specifically what is a breast self-exam, what do they need to know. We try, again, not to over-intervene, so not to do any screening in the teenage years, but this does make transition of care really important, especially for young women, to get them involved with an adult cancer risk program so that they can get the screening that they need in a timely way. I know as a pediatrician, we are a very warm and fuzzy place to be getting your care. And that transition can be really hard because it's coming at a time of life where teenagers are really struggling to kind of take control of their own health. And so we really do try to support that and help them to make that transition to a new provider in a way that is clear and comfortable with good communication. And so in summary, the main manifestations in childhood are developmental and then those thyroid nodules as well. It is important to get regular follow-up, especially with a pediatric thyroid center, somebody with expertise. And the reason and Dr. Bauer will talk about this too, the reason I really mention that thyroid expertise as well is just because of that risk of over-intervention. You want somebody who's going to be really familiar with interpreting pediatric thyroid ultrasounds, what's concerning and what's not, most importantly. And then also just that if there are symptoms of polyps, that can be an indicator you need to start colonoscopies earlier. I also just wanted to thank our multi-D clinic. Anybody who has been seen at CHOP knows Allie. She's our wonderful access coordinator. She makes it all happen. And then we've recently also added Lauren as a nurse practitioner to see a lot of patients, just to make sure that people can be seen every day of the week. But then we also try to make it possible for people to be seen within 1 or 2 days by, I think, up to 9 specialists is the most that we've done. But so we have an immunologist, a developmental pediatrician, a gastroenterologist, endocrinology. We work very closely with our vascular anomaly program, derm, neurology, and genetic counseling. And then I also want to shout out our psychologist who sees a lot of our patients as well. I think having those social supports available early and normalizing that needing extra screening might mean you need extra support is really important. That's it. Thank you so much. And thank you for inviting me to speak. Really appreciate it. Okay.
Okay, we're going to continue the tradition of 2 questions, just 2, and then we'll have our doctor panel later today. Question, anyone? Go for it.
Doctor, you mentioned in polyps, they can often appear as, I think you called it like overgrown lymph nodes. What's a good question? My eldest, they found polyps when he was about 6. So what's a question I should ask to understand the difference between the
So it would be about the pathology. So when they remove the polyps, they look at them under the microscope and they say sort of what they look like. So we really only know that by reviewing the pathology. Yeah. Question.
Great. We got one more. Anybody? Anyone? You were so good. They have no questions yet, but that means later you may get hammered. All right. Thank you, Dr. MacFarland.